Welcome back to Pulamed. Today we'll be talking about HAPE, high altitude pulmonary edema. Let's proceed without any further ado. It is nothing but an acute altitude sickness, and we have got certain types in this. One is a classical variety, where the person who is not acclimatized to high altitude and is living in the low-lying area ascends to a high altitude, usually greater than 2,500 meters. And the other one is re-entry HAPE. In re-entry HAPE, what happens is the person is accustomed to high altitude. Later on, he decides to go to and live in some low-lying area for a while, and then after that period of time, when he reascends back to the high altitude, he develops the symptoms. And there is also called mountain resident HAPE. In this, what happens is the person is resident in the mountain region. There is no change in altitude, but still the person will be developing HAPE. Coming to risk factors, the most common being rapid climbing to an altitude of 2,500 meters or more. Sometimes it can be even 1,500 meters if there are congenital heart diseases like absent unilateral pulmonary artery. And similarly, we have other risk factors like heavy exercise after ascent and also pulmonary hypertension. If you see pathology here, there is exaggerated response to hypoxia. And when there is hypoxia, there is uneven pulmonary artery vasoconstriction. So you can see in the diagram how I depicted the pulmonary arteries in blue because they carry deoxygenated blood, and now there are few vessels that are constricted and few vessels are not. So from the unconstricted vessels, there will be increased flow, and this flow will be responsible for raised intracapillary pressure, and that causes pulmonary edema. And now we also have another thing, that is pulmonary venoconstriction. Because of this, there won't be flow that side, and there will be stagnation in the capillary bed itself, and this further increases the pulmonary edema. Clinical features, usually the presentation of the person will be within 2 to 10 days of the ascent to the greater altitude, and most of the times it can occur by fifth day. And the initial presentation is exertional dyspnea. It will make the person take prolonged rest as well as frequent rest compared to his peers. And the person can also have cough, discomfort, as well as generalized weakness and fatigue. If it is severe enough, it could be also cause pink shortness sputum. The person can have headache, nausea, vomiting. And when vitals are checked, there can be tachypnea, tachycardia, decreased oxygen saturation, the SpO2 is going to be low. And on examination, the person can have cyanosis. And on auscultation, there can be crackles in the lung. And there is also a definition called Lake Lewis definition. Just remember the name, no need to go to the depth. Among investigations, we have plain chest radiograph, where we will be seeing fluffy cotton wool opacities, usually in the right middle and lower zones of the lung, but they can also be there bilateral. And we can also have right ventricular enlargement that we can see here in the diagram, where the apex is uplifted and rounded. And there can be even a prominent pulmonary artery that I have depicted in the blue in the diagram. And other than this, the ultrasound can show comet tails and ABG can show hypoxemia. So how do we prevent HAPE? That is by slow ascent. You do not ascend fast, and especially when you cross 3,000 meters, you are going to ascend only not more than 500 meters in a day. And that too, you will be taking a rest day after every 3 days. So this is what you are supposed to follow. And once you have reached greater altitude, you are not supposed to do any heavy exercise for at least 2 days. Pharmacological prophylaxis is given if there is history of HAPE. So preferred drug is nifedipine. Nifedipine is the best. And if nifedipine is not available and you have other drugs, you may use them like PDE5 inhibitors, sildenafil, tadalafil, as well as inhaled beta agonist, salmeterol, and dexamethasone. The complications we have is in cases of HAPE, there can also be development of high altitude cerebral edema. So that is something you should look for. In case the person is remote hilly area where there is no access to hospital, then the best possible thing that can be done is just take the oxygen, whatever is there with you, portable cylinder, and connect it to the person, and then plan the descent. At least 500 to 1000-meter descent should revert back the symptoms if it is a mild case. Then next thing is, in case there is no availability of oxygen with you and there is no access to the hospital, if you have a portable hyperbaric chamber, Do use it because it will simulate the descent and it is much helpful if there is no feasibility in descent. Suppose if you have a very good hospital nearby, better to take to the hospital because anyway they will be going to start them him on oxygen. And when oxygen is given, since it is the root cause, the hypoxia, the oxygen will be reversing this. So the target SpO2 that is supposed to be maintained is greater than 90. Suppose you do not have access to any of the things I mentioned above, at least if there is nifedipine, give nifedipine. If there is no nifedipine, give sildenafil or tenofovir. Suppose even in the hospital, the person is not responding to oxygen, nifedipine, then start him on the CPAP. Thank you for listening. Do subscribe, share, like, and comment.